Evening, everybody. Welcome to the second Gemas surgical master class. I think today we have got a very important topic. It is a benign pancreatic diseases, and we have got two great speakers, Dr. Manoj Rao and Dr. Dev Kumar Roy, for dealing with this topic.
Manoj,
I would definitely hand over Dr. Dev Kumar Roy to get on with the proceedings.
हाँ देखो अभी एक फोटो स्क्रीनशॉट भी भेज दिया तुमको देखो जूम में जाके ना वो मीटिंग आईडी और ये डाल दो
I think while Dr. Deb is busy there, I'm going to be the moderator for the session today. This is Dr. Jignesh Gandhi from Mumbai, and today, as an online scientific activity of GMAS, we are going to have a second session, which is going to focus on a very interesting topic of laparoscopic benign pancreatic surgery. So we have with us two expert speakers today, Dr. Manas Sahu, who is head of Department of AIMS Bhubaneswar, and my dear friend, Dr. Dev Kumar, who is from AMRI Hospital with an extensive work done in HPB surgery. And we have got two expert panelists, Dr. Sumanta, who's just returned, a few months back from UK, completing the CCST training and worked in a center with high volume. And it will be very interesting to know his views on this. And senior consultant, Dr. Kaushik Bhattacharya, who is from Siliguri. So everybody there, it's going to be very interesting. We would encourage you to ask as many questions as possible. While Dr. Manas Sahu is going to join the session, I would request one of the panelists to kind of just contact Dr. Manas and then get him on board. And Dr. Dev Kumar, in the meantime, probably you can start and I'll just coordinate of getting, so we can have, hello, good evening, Dr. Manas, good evening. Yeah. So we've just done the introduction of the whole session.
Okay, fine.
And I can see your beautiful hospital in the background, and I would be happy for you to start with your first session, which is going to be on laparoscopic LPGA. So over to you, sir, to start your session. Thank you so much.
I think I'm hearing some other noise as well.
So I would request all of us will mute ourselves, and we can just start now, sir. Thank you.
Manas bhai, namaskar.
Hi, namaskar.
Dr. Kaushik, I think all of us we will just mute ourselves so that we can just focus on that. Thank you.
Is my screen set? Namaskar.
Yes, we can see, sir. We can make it full screen and start. We can see that. Thank you.
Okay. Okay. Good evening, everybody. Thank you, Dev Kumar. Thank you, Jignesh. Thank you, Kaushik. Thank you, Sumanda. I mean, it's a pleasure to be amongst. It's a pleasure to be amongst all of you today, this evening, with a fantastic topic that you have chosen for the benign pancreatic surgery. Jignesh, somehow or other, I am hearing my noise back.
Sir, have you kept your mobile somewhere nearby? Because that's the reason. Otherwise, what I would suggest is that you can take off your headphones and speak directly, because that's the echo which is coming because of the headphone.
Is it?
Yeah. I think you can speak directly, sir. If it's from your laptop, it will avoid that echo. No, we can't hear you now. I think you'll have to unmute yourself. Sir, you can speak directly. I think that will be better. No, we can't hear you, sir. We can't hear you. I can see your screen. I can see your slides, but I can't hear you. No, sir, you're not audible. You're not audible. You are not audible, sir. Do you want to join the link again? I think you can try that. No, sir. Yeah. So maybe you can disconnect and then come back and join again. Dr. Deb, is it okay that we can start with your talk in the meantime? Till we get this technically done? Yeah. Okay, fine. So I think Dr. Deb, you can share the screen till we sort out with Dr. Manas. Please go ahead with your talk on laparoscopic cystogastrostomy. Thank you. Yes, we can see your screen. Please go ahead, sir.
Yeah, okay, yeah, fine. Right, sorry for that. I got Manas, but anyway, it doesn't matter. So today's our topic is benign pancreatic surgeries, and I'm going to concentrate mainly on pseudopancreatic cyst kind of stuff. So I'm going to present one cystogastrostomy, and there is one video-based presentation on pancreatic cystojejunostomy as well, which was a very interesting case. I will tell you later. Now I'll start with the video straight away. And this is I think we waited for 6 months post acute necrotizing pancreatitis. The CT scan shows a huge mid-body pseudocyst compressing onto the stomach. He was having difficulty in eating. Had infection in the beginning phase, but at the time I operated, he was non-infected. So in the same video, I have two different techniques, two cases. First one is a clear cyst. There's not much debris inside. So them I prefer doing an internal drainage only. And the second one, there's a lot of necrotic pancreas inside, which I prefer doing both internal external drainage. So I'll show you both the techniques here. Now I start the video. Sorry. Is the video running?
It has not come up yet, but I think, yes, now it is running.
Exactly.
Yes.
Yeah. So basically, yeah, I've gone through the history. No, this is a different one. No, sorry. I go for the first one. This is the second case. This is cystojejunostomy one. Yeah, this is the one. Yeah, it started now? Yes. So basically, port positions almost same. I normally prefer a parumbilical optical trocar, and then 2 5mm in the right upper quadrant, and the epigastric area, and then assistant port 5mm to the opposite side, maybe in the left lumbar area or left lung, depending on size of the abdomen. So basically, you open up the anterior gastrotomy, you do, then you go for the bulge. At times, this technique is difficult because if the mucous membrane is not very flat, a lot of rugal folds, then at times it is difficult. But we always, aspirate and then go through that area. And I find at times a hook is a better tool here because the harmonic actually it doesn't work when there is water in it. And then as soon as I open up, then I go for fixation of the wall because in open surgery, you can put your finger and do the stitching, but here you can lose it by too much of pressure. So I normally tend to use a 20 PDS and do the closest margin first. And we do kind of figure of 8 suturing, which actually does the hemostasis as well as fusion of the two walls. And then I normally remove a disc of the cyst wall along with the mucous membrane. And it's my standard practice to always send that for histology in case there is something else turns up. And then finish up stitching the opposite side of the wall as well. So it's basically a circumferential hole, about 2.5 centimeters hole. Then I tend to put my telescope through the epigastric port and put water in it and have an intracavitary view. And here you can see nicely with an epigastric port, you can go directly inside. The structure lying at the back is basically the portal vein. This gentleman had whole pancreas almost gone. So you can see there's a granulation tissue and all, and a little bit of debris. So we don't mind just taking it out and do a thorough lavage with normal saline. And then I tend to put the tip of the Riles tube, little few holes inside the cavity, so that post-operatively I at times use a lavage through the Riles tube as well. And then standard closure of the anterior layer of the gastrotomy with the same 20 PDS. And I tend to do that continuous suturing. I mean, you can use endo stitch as well. And I'm not very conversant with endo stitch, but endo stitch is a good toy where you can do the stitching very quickly. So after doing the first layer closure, I do a second layer, inverting suturing. So this is the second layer going on. And then wash out and drain. And the next case I did actually last year, I did back to back within 2 weeks. I did 2 cases. And this guy was had actually a lot of dead tissue debris inside. So I removed as much as possible. Not necessarily have to take it outside actually. Sometimes I just stick it inside the stomach so that it comes out through the stool. And then rest is all same, so I did not repeat the whole thing. And now how I do that external drainage procedure for temporary is that after we put a 22 French Foley 3-way catheter it's a direct puncture hole, and then put it inside through that hole. Yeah, and that goes through anterior gastrotomy, and the balloon part I stick inside the cavity through the cystogastrostomy I have made. And then actually I inflate the balloon so that it does not come out while I do the hitching stitches like in gastrostomy hitching stitches. So I inflate the balloon inside the cavity, and we can actually have a view through that balloon is getting inflated inside, which I don't see it here, but anyway. And then give it a tug up so that it doesn't, like I'm pulling it up so that I make sure the balloon does not pop outside into the stomach. And the reason I put it there is post-operatively I can use the lavage through that. And that, so all debris actually comes out. So then the standard closure of the gastrotomy in 2 layers, I do with same PDS sutures. And then as we do a hitch stitch with the anterior-abdominal wall, so what I do normally, I use 2 transversal sutures because and laparoscopically it's very cumbersome to stitch it to the anterior wall. So I use 2 sutures to pull it up towards the wall with transversal suturing. This is the second layer going on. So after the second layer, we'll go for the hitch stitch to the anterior abdominal wall. I'll make it fast. So this is the second layer gone. And now with the pull up stitch, then I use some reinforcement sutures anteriorly posteriorly so that the gastrostomy tube is nicely hitched to the anterior abdominal wall, the peritoneum. So there's no leak comes out. And then post-operatively, I normally use a washout. After 48 hours, we give lavage and washout. And then once I'm happy that nothing dirty is coming, because it's 3-way, so you can put lavage through one and effluent to the other one. And once I see there's a clear effluent coming out, and then I sort of clamp the tube into the abdominal wall and send the patient home and remove that tube. Initially, first few of the cases, we did an endoscopy while removing the tube after 6 or 7 weeks. And then we remove the tube and then do the endoscopy and have a look inside the cavity. And that's what I do. But nowadays, I don't do that anymore. There's another procedure. So we just take it out once I'm happy that after 6 to 8 weeks, we just take the tube out. The reason I do that, because a couple of cases I had terrible problem just by doing an internal drainage, because we did not look inside the cavity properly, and there was a lot of dead pancreas tissue was there. And initially it was not infected, but after communicating with the stomach, that got infected. And that guy, after 4 or 5 days, so I had to take him back to theater again and had to do a small open cut and remove all the debris, pus and everything, wash out, and then redo the whole procedure. So I think this technique actually helps. So whether I'm going to do an internal drainage only or external drainage, it depends A on the CT scan, and B just by the look of the what color stuff is coming out and whether there is a lot of debris inside or not. If there's a lot of debris, then I usually do an internal external drainage. And it acts as a stent also. It doesn't allow that hole to close down, the cystogastroscopy. So it works really fine. And now the next case is very interesting. I did a cystogestomy on this lady. This lady actually, during the whole this pandemic time, she suffered 2 attacks of pancreatitis. The first attacks got settled down. There was it's a 5-month history of pain abdomen. She had 2 attacks of pancreatitis, and the CT scan revealed there is a cystic SOL near the head of the pancreas. That created a lot of confusion whether this is benign or malignant. A lot of tests has been done, and since the CT scan is very interesting. There is a thick wall cyst and is directly communicating with the main pancreatic duct. She had endo-US also, and by endo-US guidance, they aspirated the fluid in another hospital, and the drain that amylase level of that fluid was 60,000. So this is a direct communication with the pancreatic duct, and there was no calcification actually in the rest of the pancreas. I didn't put all the CTs. There's no calcification. So that excludes a kind of chronic pancreatitis situation. This is again causing trouble playing. Okay. So again, with the standard ports, I went inside and then we could see, I think I have to go to the main, I just closed this one, but this is creating a bit of trouble. Just a minute. To go directly from the video. Is that one okay? This will play all right, I think.
I think the screen has got stuck.
Is it going
can't
now?
see them. No.
You can't see?
No, we can't. I think, at least on my screen, it is showing that it is stuck.
No, yeah. I'll do that. Do one thing. I'll share my screen. Look. Can you see now? No.
No, it's not coming.
No,
Okay.
it's not coming.
Just a minute. I have to share the screen. Screen sharing. I have to stop that one and share this one. Yeah. Now we'll see. Yes? Have you got it?
Yes, we can see. Yes,
Yeah.
please go ahead.
Yeah. So here there was, the cyst I could not see initially, but I could feel the bulge laparoscopically. It was close to the hepatic flexure. So I took the hepatic flexure down with the help of ligature because there's a lot of vascularity there. And after exposing the cyst to it, there's a nice smooth cystic wall. And then I punctured it, and you see that clear rice water fluid coming out. And then as soon when I opened up the cyst wall, it's hanging a bit. So it is quite a thick wall was there. So I removed. My plan was to remove again a part of the cyst wall and send it for histology, because you never know whether this is a cyst adenocarcinoma or something like that. And then after de-roofing it, so I made a loop with using the endo-GIA staplers. And then, yeah, this is the endo-GIA going on. So I did the loop formation. This one was a very expensive one, Jignesh. I used the new COVIDian, this stapler, the automatic one. 15 lakhs is the gun with a sheath and all.
Okay.
I didn't use the 50 lakh. This was a demo basically. The
No, you
cartridges
are
are
you are a
cartridges.
priceless surgeon. You are a priceless surgeon, so absolutely no problem.
But this gun is fantastic. Everything is automated. I mean, you can move and do whatever you want. This is fantastic. So I did the side to side JJ, and then closed it in. I don't know what you do. I normally close it in 2 layers. I don't find it very easy to just finish in 1 layer. So after doing the 2 layers, we close the mesenteric defect, and then I made a window into the transverse mesocolon and took the jejunum up, then made a hole into the jejunum. I normally prefer initially the hook and then go with your harmonic scalpel maybe. And then the trick of all this, I think Manas will tell also how big you want to make the hole, because jejunum tends to always get bigger and bigger with the pull. So I normally make it a bit shorter than the actual hole in the cyst wall. Then I started suturing the cyst wall, the posterior wall first. First stitch is conal, and then we come through the back and do continuous layer suturing of the posterior cyst wall with the jejunum. I made it a bit fast so that it goes fast. Is it running okay?
Yes, yes.
Yeah, no problem.
So once the process, see how thick is the wall. I mean, just in 5 months, they can be so thick. And actually, this case was my radiologist, Manoj, actually he said, is the whole, if you see that CT again, the whole MPD, it is actually a pancreas divisum anomaly. The whole MPD is draining at the top part of the papilla, which is blocked, and that has blown out and formed a cyst. So the whole MPD is communicating with the cyst. And the lower part of the uncinate procession area had a separate duct going into the duodenum, the major papilla. So this was basically kind of group pancreatitis. Actually, the histology came back as just chronic pancreatitis histology, no malignancy. When we checked the fluid level also, we checked CA19-9 on the fluid also, which was normal. So clinically, I was very confident. This lady actually went to Tata also uh, because they thought it's a cancer. She's diagnosed of the pancreas. But they said, no, it's not. So I did the operation. So now I'm finishing the anterior cystogeneostomy. And usually you see the lower wall, nothing happens, but I normally tend to, even for PJ, I tend to put after the running stitch, one or two interrupted suture to reinforce the anterior part. And then just wash out, nice wash out, and the drain, make sure gauge, because we put a lot of gauge pieces inside, make sure you do a proper count. And I just left the drain for 3 days, and actually she did very well afterwards. And just run it. I think, yeah. So this is done. There's few more buttressing sutures, wash out, drain. Now you can see the jejunum nicely stuck to the cyst wall. I actually didn't bother to close that gap there because it was not a very big gap either. And then I just run the intestine, make sure everything is the rule loop. I just run through, is going down, down, down. Then the JJ does the biliary limb, and then just to drain and come out. And this lady actually went home in day 3 or day 4, and she's doing very well. So that was an interesting one, cystogeneostomy. Now I go back to, I just stop this one and go back to my PPT. I have just one more slide thing to go for, and then we're done. Let's share this one now. So now I summarize now, because the indications, you have to be very sure whether you're going to do anything or not. Because we tend to sit tight on a lot of pseudopancreatic cysts if they are not symptomatic. Can you see my, yeah?
Yes, yes, we can see.
Yeah. So the indication has to be very straight, like either it's causing a mechanical compression or causing an infection recurrent or causing a pain. Otherwise, and other thing in the CT, we need to look for whether proper triphasic CT immediately before surgery is very, very important. Otherwise, if you treat somebody who's had a CT scan done maybe 3 weeks back, 2 weeks back, and you tend to just go on and operate, and you may not find the cyst. I mean, they at times they drain internally. So I always do a repeat quick CT just day before the operation. Yes, this is another good option. Expertise, you need to be present. It is expensive, and repetitive procedures have to be done if you want to do it endo-US guidance drainage. Laparoscopic drainage, I think, is feasible, very cheap, and is one of procedure majority cases. Just one go, you just drain it, and they are fine. Thank you. So I finished my presentation now. So if you're asking,
Okay, thank you. Yeah, so thank you so much, Dr. Deb. And before we start with Dr. Manish, I think we'll just have few set of quick questions. So let me start with you, Dr. Deb. How do you do the selection of your cases? How do you select your cases for laparoscopic approach?
Yeah, CT scan is very,
Can
very
you
important.
Can you stop sharing your screen so that all of us can be on the view? Yeah.
Okay. I just stop it. Yes. Okay.
Yeah. So the first question to you, Dr. Deb, selection of case.
Selection of cases, it has to be big enough to cause mechanical effect, like patient cannot eat, mainly cystogastroscopy cases like that, or having recurrent infections, or in a CT scan, if you see, like a lot of cases, you will see that there's mid-body big cyst, and there's a lot of tail still left. So what happens, they have a dark disruption in the middle. And in those kind of cysts, they usually tend not to close down naturally. So other collections, if it's just a pseudopancreatic cyst, just a collection peripancreatic, if the duct is intact and if the patient is not symptomatic, I just sit on them. I just don't operate on them. And majority of them actually disappear nicely. Okay. But if the duct disruption is suspect, then they usually grow bigger and bigger and become symptomatic.
Okay. Dr. Kaushik, coming to you, what do you think should be the right timing of surgery from the attack of pancreatitis? Because this is a very gray zone. So how long do you wait before you plan for a cystogastrostomy?
Yeah, I think Dr. Devkumar has showed that 6 to 8 weeks is the usual thing when we wait for this. He has showed in his slide. I just want to ask one more thing to Dr. Devkumar Rai. So that Foley's thing which you showed us, do you do it in all the cases, or you select your cases for putting the Foley's catheter which you showed in your video?
Yeah, I told it actually, you probably missed it, but it depends on the color of the fluid inside. If you find it's an infected kind of fluid like pus and all there, and when you do a inside view with your telescope, there's a lot of debris inside, a lot of dead pancreas still you can see, which partly you can remove, partly you can't. And those cases I do, it's a selective approach.
So we infer that when there's a lot of necrosis and you don't want to do that necrosectomy, you put a Foley's and come out. Is that what we infer?
Yes.
Very interesting thing.
So I would, Dr. Dev, just add one thing, because I always, when I teach, because there are a lot of postgraduates who want to watch, pancreatitis is basically the burns of the chemical burns of retroperitoneum. So like in burns, when you do an escharrectomy, you wait for 6 weeks, 8 weeks, 10 weeks, 12 weeks. The more you wait, I've seen that necrosum comes off very nicely, and sometimes I've removed large chunks of entire pancreas so that you can avoid this additional procedure of doing an anterior approach where you can put it. But it's quite interesting to know about it. Coming to you, so that Foley's thing we can probably avoid. That's what even I felt. Coming to you, Dr. Sumanta, our panelist, Dr. Sumanta, what is your experience? Have you seen any cases, and again to Dr. Dev as well, of anterior cystogastrostomy? Because we all know pancreas is a retroperitoneal organ, but quite often in our practice, we have seen a cyst which is on the anterior wall of stomach. So how do you manage those cases, Dr. Sumanta?
In my personal experience, I have never seen anterior cystogastrostomy personally, but that is feasible. But always posterior cystogastrostomy, that's what we have done so far.
But then because of the anatomical location, Dr. Dev, have you encountered such a case? And even Dr. Kaushiraka, I'll ask you as well, because I've seen quite a few, and I'll tell you my experience once we discuss this. Yes, Dr. Dev.
Actually, it can be actually a dumbbell set, by starting posteriorly, then coming anteriorly. Otherwise, I mean, pancreas is a posterior structure, so you cannot just have an anterior seat sitting in front of the stomach. So they are usually dumbbell. They have kind of communication in the back.
And it goes away with your posterior gastrostomy. If you do the posterior,
So we have seen some patients, where we have had a very tricky situation, and I felt it was communicating. But in those patients, then I had to put in a separate pigtail. But yes, there are literature reports where you can do an anterior cystogastrostomy. It's just that your camera person has to get used to it and do that. Dr. Dev, coming to the next question, any tricks and tips of managing bleeding? Because you are decompressing a large cyst, and you suddenly find that there is a lot of bleeding in the in the cyst wall cavity. So any tricks, or have you encountered anything in the past?
I mean, the major bleeding points you see is the trick is when you just go into the posture of the stomach, because at times there can be the splenic vein can be thrombosed, and there can be a lot of collaterals going behind the stomach. In that case, if you see in a CT scan, you can make out. So if I see there's a lot of veins going behind the stomach, in between the cyst on the stomach, I tend to use a ligation or a sealing device rather than using a harmonic, because harmonic can fail in those kind of situations. And you go very slowly, actually. You don't jump on and open up and go. And the other complication I would like to mention, one of my case, that patient, actually I did the operation after 5-6 months even, the persistence is there. So the reason I'm telling you this, that we all learn from our mistakes. So I went inside and had an intracavitary view. There was some, at the top of part, there was some dead tissue was there. So I did a bit of over-enthusiastic debridement to that area, And then I just did internal drainage only and came out. 2 days after, he is peritonitic, So I had to go back because the posterior superior part, the wall, where I did the debridement, and that part actually just gave away. It was very thin part there.
Okay.
And he had basically the stomach content gone through that hole and had a peritonitis. So I just went back in with the laparoscope again on day 4, I think. Laparoscopy, wash out, and just let 2-3 drains and come out, and he did well after that.
Okay. Dr. Manas has been, Dr. Manas is around. Dr. Manas, before you start your talk, I would like to have your opinion. In today's era, when we have such sophisticated radiological investigations and we can do everything, do you think is there any role of doing a biopsy of the cyst wall? Because when we were postgraduates, I'm sure our bosses always said that they used to send a small part of the wall and for histopathology. So do you think that is still going to be the practice, or we think we should get away with that? Yes, Dr. Manas.
Am I audible?
Yes. Please go ahead.
Fine, thank you. So I think in the present era, 3 investigations when they are in choice, like ultrasound, CT scan, and MRCP. Probably one investigation which is really always required is a CECT. But the only disadvantage of a CECT that we do not know what is the necrosome load or a WPN, I mean, world of necrosis. We do not know the necrosome load, for which ultrasonography or endo-US becomes always a mandatory investigation. You are absolutely right, Jignesh. Around 99.9% of cases, before we embark upon a laparoscopic procedure for a pseudopancreatic cyst, we are quite sure that these are not IPMNs. So, so most of the scenario, we rarely, in fact, we need to just send that disc of tissue that we are being taught from our postgraduate days. When you take out that disc, send always for a histopathology. Might not, but yes, from a medical legal point of view, it's always required that you need to send it just to record that the tissue was sent and the histopathology was negative. But I'm pretty sure in 100% of cases, we always get a benign report.
Absolutely.
So, and the second thing I just wanted to comment on regarding the bleeding issue that you highlighted. Quite often, if I find a splenic artery aneurysm with the pseudopancreatic cyst, I do a pre-operative embolization and then take up for the decompression, because the moment you decompress, the aneurysm, they surely get a space to burst open. That makes your life miserable. So it's always better that if we pre-operatively, preemptively embolize them and then take up for a laparoscopic decompression, things become much better and much under control. You don't need to panic at post-operatively.
Okay. Is there any size guidance to how big this splenic artery aneurysm you are going to call first?
I think quite often, if it is in an average practice, I find that splenic artery aneurysms more than 2 centimeters, I always try to preemptively embolize them, just to stay on the safer side.
Dr. Jignesh, I just add one comment to what you said, the bleeding one, very interesting thing. The literature says very well that one of the most common cause of conversion to open surgery is bleeding. And the reason they say very clearly that surgeons who are doing this laparoscopic cystogastroscopy should reserve a blood. I mean, you need not reserve, bring it to the OT, but should ask for a reserve, because suddenly if you want, you require blood transfusion.
So one thing, which comes out of this bleeding point I have seen is, and when I was taught, yes, it is known as a camembert cheese appearance of the necrosome. But when you handle it, my boss always used to say that handle it with care as if she's your girlfriend. Be very, very gentle, because if you're trying to irritate it, you're going to have a lot of bleeding in that area, and then you will have a trouble. So one question to all the panelists, we'll start with Dr. Sumanta. Any experience on stapled cystogastroscopy? Because I am a big fan of doing a stapled posterior wall. So I would like to have views of all 4 of you. Let's start with Dr. Sumanta.
My choice is always staple, because you can
what color cartridge do you use?
If it is just cystogastrostomy, just a clear fluid, blue stapler, thick fluid, green stapler. So that's what I do generally. And
yes,
also
Dr.
the good.
No, I have not used.
Okay, you have not used a stapler. Dr. Manas?
I personally till now never ever used a stapler. I am a switcher man. So since I am working in a public sector hospital, even though my hospital, I am fortunate to get all staplers free, but I never have used a stapler for the cystogastrostomy type. I mean, for the cystojejunostomy or cystogastrostomy, I always prefer a switcher. And I feel always it's much more comfortable, whether irrespective of whether it's a pseudocyst or a walled up pancreatic necrosis, doesn't matter in any way.
Sir, I also represent public hospital at KEM, but let me tell you, for the posterior wall, what I feel is if you have a staple, you have a consistency, because you're most of the times it's the stomach wall varices or the pancreatic wall which can give you a trouble. So I think posterior wall stapler probably. Yes, Dr. Dev, your opinion, have you used that fancy stapler for the posterior wall staple?
I have used staplers. And I mean, it depends on the thickness. When you puncture it, you know the thickness. Also in CT, you can measure. But the cartridge, I would go for a vascular stapler, like a white cartridge.
So I have sometimes used white, sometimes I've used golden. Maybe with experience, we can make out what exactly is happening and, how does one go about it. So I think that has been fairly good, just for the postgraduates who are watching. A lot of times this funny question is asked in the exam, that why the food doesn't go into the pseudocyst when the patient eats the food. So maybe anyone wants to take that question? Dr. Manas?
Yes, I think that's a very funny question always asked, because since we decompress the cyst, after 48 hours, we do not find that cavity persisting.
Absolutely.
After a week, we do not find anything in that. So it's absolutely one wall almost. So there is no scope of getting any fluid or food into it. And another question which quite often is asked to all these postgraduates, defining, differentiating between a pseudocyst and a walled up pancreatic necrosis. To be precise, acute edematous pancreatitis after 4 weeks usually tend to go for a pseudocyst, whereas acute necrotizing pancreatitis after 4 weeks usually goes up to a walled up pancreatic necrosis. And if we find a necrosome load of more than 30%, that's probably one of the indication that we always go for a laparoscopic drainage, or otherwise less than that or a clear pseudocyst, like endo-US guided drainage is also quite good enough. And in the era of lamps, lumen opposing metal stents, endoscopies, GI, our gastro friends are equally competing with us. But I must say that surgeons are always required for patients who have got a good necrosome load. Laparoscopy is always the only answer. But all panelists will agree.
I fully agree with you. We have seen a lot of endoscopies having a lot of venture, thick necrosome. They put in a stent, they dilate that stent, one more stent, 3 stents. In fact, I had a patient where there were 7 stents put in, and then at laparoscopy I had to remove all of them and undo. So I think that has been a fairly good discussion. Just to sum up what all the expert panelists have seen for the benefit of the audience, about 70 to 80% of cysts which we see today are pseudocysts of pancreas in the pancreatic region. But on radiological investigations, if you see any kind of cobweb or a honey web formation with an absent history of alcohol or cause of pancreatitis, or no changes of chronic pancreatitis, please watch out that you are not dealing with a pseudocyst. It could be something else. And as the panelists have rightly said, today with an advent of good laparoscopy, we can do a posterior cystogastrostomy very comfortably. You want to do a hand sewn or staple, it is equally good in your hands and it is safe. And what Dr. Dev pointed out was a very nice technique where you can give a wash. So if you are suspecting that, put in that tube. And management of bleeding, we've already discussed, Dr. Kaushik bringing out some fantastic points. So I think it has been a fairly good discussion on this topic. And I think if we have any other comments from the panelists about this, otherwise we can move to the next talk. Yes, Dr. Kaushik, please.
I just want to congratulate Dr. Dev Kumar for the excellent videos. He showed fantastic 3 cases.
Yeah. So for us, he's described all the 3 scenarios, and we're looking now for more fantastic videos from Dr. Manas. So probably, Dr. Manas, now I'll take over to you to start with your talk, and then we'll have the discussion. Thank you so much.
Sure. Is my screen visible now?
Yes.
Okay, fine.
Yes.
So thank you very much for this invite to the Gemas. And I have been given the responsibility to talk on laparoscopic longitudinal pancreaticojejunostomy for tropical chronic pancreatitis. In fact, I bring greetings from AIIMS Bhubaneswar and from land of Lord Jagannath to all of you. So before I go on to the laparoscopic management of longitudinal pancreatitis, tropical chronic pancreatitis, I must say that we cannot stop waves coming in the sea. We just need to learn how to swim with it. And in the present era, if we are not updated, we are outdated. So indications for surgery, whether it is for laparoscopic surgery or open surgery, they all remain the same. Failure of a medical treatment, severe and intractable pain, inability to eat adequate amount of food, and investigations revealing a dilated pancreatic duct. So the main goal of surgery for a tropical chronic pancreatitis is pancreatic decompression by longitudinal pancreaticojejunostomy and coring the head for sustained pain relief. That's probably the main catch in this surgery for chronic pancreatitis. And the aim of laparoscopic surgery is just to provide the benefits of minimal access surgery. So if we can maintain surgical principles with cosmesis, then why not laparoscopy? Why always open? The mindset has to change. But I know this is the road less traveled. People always are not in favor of laparoscopy just because people think that coring is not feasible. It is unnecessarily expensive for the patient, and it is cumbersome for the surgeon as well. So the advantages of laparoscopic LPJ is surely known to everybody. It carries minimal morbidity, early recovery of bowel function, cosmetically highly acceptable, no compromise of surgical principles at all. But who are the candidates of laparoscopic LPJ? Is it that all patients that we get are post for a LPJ? Do we need to take them for laparoscopy? Surely not. I'm a big fan of open phrase, but still, you have to select out candidates who can comfortably, we can deal them laparoscopically. Patients who are symptomatic, needing surgical decompression, and a sufficiently dilated pancreatic duct. To be very precise, when I started off doing a laparoscopic LPJ, I was choosing main pancreatic duct diameter more than 12 millimeter. Now, probably after doing some good number of cases, even though not a very large series, but it's quite good number for from my point of view, for tiding over the learning curve, now I am able to take a case even 10 millimeter or 11 millimeter. So if the usual investigations that's for even open surgery are all done for a laparoscopic LPJ. So the journey in a laparoscopic LPJ, not that if you're planning a laparoscopic surgery for tropical chronic pancreatitis, you should not just jump for a laparoscopic phrase just the next day. If I have a patient today to undergo LPJ tomorrow, please don't jump for lap phrase right away. You have to choose cases and start doing an assisted laparoscopic procedure where we just need to convert the umbilical port and take the bowel out, do an enteroenterostomy outside, and we do the pancreaticojejunostomy intracorporeal. This is the way that I have progressed through my journey through laparoscopic LPJ. And after a few cases of assisted laparoscopy, then I switched over to laparoscopy pustules procedure, not phrase. I mean, those patients where the inflammatory mass in the head was not there, where the anteroposterior dimension of the pancreatic head was less than 3 centimeter, there was almost no stone load in the head of the pancreas. Probably those are the good candidates where I picked them up for a laparoscopic pustules. Then I converted myself to total laparoscopic LPJ and laparoscopic phrase. So this is a sequential stepwise progression. It's just not that you can surely jump into laparoscopic phrase, then you tell, no, that was terrible bleeding, I could not do it, it's all useless. That should not be the criteria. So what's the technique of doing a laparoscopic phrase? The patient has to be in a modified Trendelenburg bug and semi-lithotomy position. The lesser sac is approached through the gastrocolic omentum. Identification and exploration of the main pancreatic duct, rule loop formation, pancreaticojejunostomy, anastomosis intracorporeally is a total, whether it is a assisted or total, you need to do it intracorporeally. But initial cases, enteroenterostomy outside. Once you are quite good enough, then start doing a total laparoscopic phrase, everything inside. So let's now watch the video. If this is how we place our ports. First of all, I must say that the port placement goes like this. This is the uptake port, supraumbilically placed. This is the subgyphoid port, 5 mm port. That's for your retracting the stomach and getting your access. This is the left-hand working port midway between the subgyphoid and the uptake port, and this is the right-hand working port. So this is essentially a 4-port approach. And this is how you are placed in a lithotomy. I stand between the surgeons, I mean between the legs. So it's a French position almost. Then once we are inside, the first thing that we do is opening the gastrocolic omentum and getting into the lesser sac. And this opening has to be quite wide so that there is no question of any entrapment of bowel. So whenever it is done, I mean, it is always done in a wide opening of the gastrocolic omentum. So once the gastrocolic omentum is opened up, a wide opening is done. There are few congenital adhesions between the posterior part of the wall of the stomach and the anterior wall of pancreas, that those are to be lysed. And after that, this case had got a lot of peripancreatic fat, which need to be taken care of with a harmonic. And once you start taking care of this peripancreatic fat away, you can see a sufficiently dilated duct visible to you. If you have an intraoperative ultrasound, that's a boon for you. And if you're doing a less dilated duct, that might be much better. But since my case selection is absolutely perfect, where you are sure that the duct is quite dilated, I can access them well. Probably it will never be a problem. This is the whole of the duct, right from the head to the tail of the pancreas. Then you have to put in just a spinal needle and guide it to the pancreatic duct and aspirate to confirm that you are surely inside the pancreatic duct by aspirating pancreatic juice. Then just keeping the needle there with the active blade of the harmonic, we need to enter into the dilated pancreatic duct. That's the internal view of the dilated pancreatic duct. So then you have to just go on with a hook. Those are the stones coming out. So cases are the most important thing is choosing your cases for laparoscopic procedure. That's probably the most important catch. So taking all the stones out from the body, tail, from the head. And initially, after doing this, I was doing a doctoscopy, probably over some number of cases. I just forgot doing that. I didn't do that. Initially, I tried to do this just to have a look. I tried to look into the unseen. So in fact, in one case, I could find there was a stone there. And because of my endoscopic experience, since I also do perform ERCPs, so I utilized the same thing over here. I passed in my ERCP basket and took out this stone from the pancreatic. I mean, it's almost nearer the uncinate, which was basketed out. But after few cases, I realized this is just an overkill. It's not required if you're doing a good phrase. So maybe these are the initial hitches that somebody need to overcome. So this is the first few cases of doing a assisted laparoscopic LPJ. The enteroenterostomy is done outside. Just enlarging the optic port, delivering the bowel out, the jejunostomy done inside, then the intracorporeal pancreaticojejunostomy goes off. So intracorporeal pancreaticojejunostomy goes off in all procedure, but to start up, just to minimize the time and just to have the confidence of going over and doing things total laparoscopic way, this was how initially I just took them off. So this was the cornel taken in the intracorporeal pancreaticojejunostomy, the same way that we do in open surgery, nothing different. And probably this anastomosis is much secure, much better. There is hardly ever any chance of leakage if it's done well. Probably, unless otherwise a surgeon is that damn care, probably nothing should have happened. These are a few second reinforcing sutures. So once the intracorporeal anastomosis is complete, that's the immediate post-op view. That's the enlarged optic port. These are the stones. And this is at the post-op where you don't find anything, almost it's not a big scar. Then I switched over to laparoscopy phrase. So I did first a division of the bowel. Then the head coring with a combination of energy sources. If it is well done with a hook, that's fine. Or otherwise, quite often now I've started using a bipolar Maryland dissector, coagulating with initially, or taking preemptive fluoroproline sutures on the head and coagulating, then excising them with a harmonic whenever you feel it feasible and better. Then the enteroenterostomy. And this is the final closure of the mesenteric rent. This is the post-op picture. So lessons learned so far, probably the most important thing for taking up a laparoscopic procedure for tropical chronic pancreatitis is selecting your case. A surgeon should not just get tempted to jump in and take up any case of chronic pancreatitis for a laparoscopic procedure. And surgeon is probably the most important critical variable. You need to have good advanced laparoscopic skills of intracorporeal suturing and the confidence to do it. And you should have good optics and energy sources available in your theater. That's probably the most basic thing that somebody can ask for. So for 36 cases, and these are my few of the experiences. This was published in Surgical Endoscopy, the series. And I had the opportunity, in that article also, I had just mentioned how selectively and progressively I went ahead and went from assisted to phrase. This was fortunately also presented in the SAGES. So thank you very much for your kind attention.
Dr. Manas, that was a fantastic presentation. And you have brought out a very important point that the surgeon has to be an endoscopist as well, because when you have a combination of two things together, that's where it helps. So before I start the question, I'll probably ask the first question to you, Dr. Manas. You showed it very easily, putting the needle from the top and removing the juice from the pancreatic duct. I can tell you, I initially have spent a couple of hours because in the open surgery, I have learned that when you roll your finger from head to from top to bottom, you can feel a subtle groove there. Yes. But in laparoscopy, I think we need to tune our instruments to that. And what I have found, it is usually at the junction of 2/3, 1/3. That's where you have to probe. So I would probably go to all of you one by one. That how do you identify your PD? Yes, Dr. Manas, how did you do it in your initial stages?
I think I'm very clear on my initial phases to till now. Absolutely, you are right. Initially, it was hell of an affair locating the duct. That's the reason why I told you. The first cases I was choosing, it was all 12 to 14 millimeter dilated duct. So the duct is quite sufficiently dilated at the first go. So as you told, in open surgery, we have the habit of palpating the groove as we palpate, roll our finger from the head to tail. Gradually, you also need to experience your instrument and that tactile sensation feedback, the palpating the duct. And believe me, if you're having a sufficiently dilated duct, as I showed in this video, once I denude the peripancreatic fat, the dilated duct just stands in front of you. Know that this is nothing but the pancreatic duct. Just the needle is pricked just to confirm that this is nothing other than that. So probably that's the reason why I've told, if you are selecting a case, then absolutely it's not a problem. But if somebody is selecting a 8 mm duct in the initial case, and then it's a hell of an affair getting the pancreatic duct. And in that case, that's what those who are having fortunate to have a IOUS, even having a IOUS also, it will be difficult still.
It is difficult.
Still difficult. So if you're selecting a good case, the duct is sufficiently dilated, I think it should not be a problem at all.
Okay, Dr. Deb, any trick from your side? Identification of PD, any tricks?
Yeah, I mean, if the patient is thin, majority of them are, because they're suffering from chronic pancreatitis so long, but some of them are really chubby also. So I cannot reach to that needle. So at times, if I'm sure there is the duct, I can just put a small needle inside. I just put the needle inside, either blue or, and then just prick it. Like last month, I did 2 cases. One, I did laparoscopy, as Manas said, because the duct was dilated, there's a lot of stones. And the other one I gone home yesterday, we done open because duct was not that dilated. So yeah, duct dilatation is like doing a laparoscopic CBD. I mean, if the duct is not dilated, you try and venture doing a CBD, you will be in trouble.
Dr. Kaushik,
Dr. Jignesh, a trick what I understood from the talk is, if the patient is chubby, if it's thin, you take it. If it's chubby, send it to Dr. Dev Kumar Rai.
Dr. Sumanta, any trick from your side for identifying?
No, everything is kind of said. What basically the key message from this discussion is that a laparoscopic pancreatic surgery is not a laparoscopic bowel surgery. So it has to progress. So there is a reason why kind of in 1990s we started doing laparoscopic Whipples. Then suddenly things dropped, and then at the end of 2010 we started picking up laparoscopic pancreatic surgery. And there is a reason for it, because it is not so straightforward. You have to have advanced skills, as Dr. Manas has said. You have to have a bit of a surgical acumen and how to manage in a difficult situations. And that is the key for laparoscopic pancreatic surgery. It is possible, and now things are picking up. People are doing mostly these benign pancreatic cases and distal pancreatectomy laparoscopically. And the days had now more or less arrived that all this hysterogastrostomy and lateral pancreatitis, they should be done laparoscopically because of better patient's outcome. But there are cases like less than 10 millimeter pancreatic duct where it's very difficult. And I have seen most of, because in the UK majority doctors or majority surgeons use stapler. So this LPJ also, they use staplers straight away and then close the gap. So and for stapler accommodation, you need to have a sufficient length. And ductoscopy, I've seen the endoscopy being used, and also cystoscope being used. So yes, that's we have done.
So second technical question, Dr. Manas, to you, sizing the enterotomy, the size of the enterotomy compared to the size of the duct, because that's again a very tricky thing which all of us, and then at the end of it, you have to cheat on the bowel. So what is your cutoff? How have you evolved? Then I want each one of you to share that very quickly. Yes, Dr. Manas.
I think pancreatic ductotomy, there is no second thought that it has to go well from a cord head till the end of the tail. So it is nothing less than 6 centimeter. But when it comes to the bowel enterotomy has to be a little lesser than what you incise on the pancreatic duct side, because that becomes much more comfortable when you go for the pancreatic jejunostomy. But if unfortunately somebody cuts equal length, then surely it finds problem at the end, at the angle, compromising that anastomosis. So it is all usually, as we do in any kind of a Roux-en-Y jejunostomy, whether it is hepatico or pancreatico, we always cut less on the jejunum side. The same principle also holds good here.
Dr. Dev, what is your mathematics?
Yeah, I mean, what I do normally, I make a smaller cut to the jejunum first, start stitching, and then as I progress, I assess, and then if needed, I increase it. If not needed, I just do it like that.
Dr. Kaushik,
I think that's a much better hint that you gave. It is always to err on the smaller side, cut less. Yeah. Then as you progress, you need that little more to be cut, then you cut it. It's always better to stay on the safer side.
Otherwise, the jejunum opens like a flower, and then it's difficult to stitch it. So even in open jejunum.
Yeah, if you keep if you keep 1 centimeter as a duct, please keep half, 0.5 as for this thing. And then if you require, you can increase it. I mean, I just cut half. You just keep half. Don't make more than. Otherwise, it's
yeah. So we have been doing a lot of Partingtons with Dr. Bapat from 98 times. And we always used to talk that cut only 50% and start from one end. And usually with experience, I've seen that about 60 to 70% is enough. You don't have to be 100% matching on both the sides. And that's good enough. Dr. Manas, your experience on stapled PJ, because I remember doing it much earlier. And initially, for the first time I did it, I actually did it in an open case. I said, this is looking pretty good. Why don't we do an open? So we had fired a 75 linear cutter. And that's where the whole idea came in. And, then we started doing in select cases. So your opinion on that, Dr. Manas, stapled PJ.
You mean to say the pancreatic or jejunostomy?
Jejunostomy stapled, yeah.
I have never attempted one stapler in pancreatic or jejunostomy. I am purely a switcher man, Jignesh. So I always prefer switchering. Unless the enterostomy, only enterostomy, yes, it's a stapler.
I take your comments very, very well. But sir, today stapler gives you a consistency all throughout. But again, the selection of case. You cannot have a PD full of stones and then you're going to, because the stapler will not go inside. You need to have a nice duct. So it's a very seldom selected cases that you will need. Yes, Dr. Manas. Yes, you were saying something.
I similarly, as Dev, Sumanta, and Kaushik, they were all discussing. I mean, you also about cystogastrostomy being stapled. I only some or other sometimes feel if the wall is so thick and you are stapling and probably it doesn't fire you well, it cheats you on the table. Then anyway, you are again going to suture it back. And if I'm making a good opening and I'm suturing all around, I'm pretty happy that all the necrosome, whatever I'm soft necrosome I'm taking out, the rest will surely drain out because I made a sufficient opening. That's what my personal feeling. And on this pancreatic jejunostomy, I think it will be surely not that comfortable to anastomose with a stapler than as you do it in a suture. I mean, it almost complementing your open surgery laparoscopically. That's what is my personal feeling. I mean, you have an experience in stapler, it's fine, but I feel some or other suturing pancreatic or ductal jejunostomy gives a lot more of satisfaction. Maybe it's a personal choice and feeling, absolutely. Yeah.
Dr. Kaushik, just asking you a question on how many occasions you have seen that on table you found that the head of the pancreas is a little dicey and you want to do a frozen section, because we know today that 10% of patients with chronic pancreatitis will be having a hidden malignancy. So when do you have that suspicion, and what way you feel that, okay, before I do an anastomosis, let me check a quick biopsy?
Frozen section, let me very frankly tell you, is not available in Siliguri, the place where we practice. It is not available here.
Yeah.
But yes, definitely we take a bit of tissue if I find there's some suspicious thing, and we send it for biopsy. And then we prognosticate the patient party, saying that we have done that, it can come, anything can come, then we'll have a relook, or we have to go for another for secondary surgery if required. We prognosticate the patient party if there is suspicious area in the pancreas.
Okay.
Coming to that question,
yes.
as Sik told that he has no facility for frozen section. Yes, AIIMS Bhubaneswar is well equipped with a frozen section facility, but still with that, I have till now not ever sent a biopsy for a frozen section for a pancreaticojejunostomy, because quite often, as in pseudopancreatic cyst, we are pretty sure pre-operatively that this is not a malignancy. Quite often, we are sure with the tumor markers and all the investigations that this is a tropical chronic pancreatitis. So it is quite often not required.
Unless it is quite often not required,
yeah. Unless
it
otherwise,
very rarely, yes.
Yeah, very rarely. If you are thinking, yes, there is a suspicious, some kind of a mass lesion associated with chronic pancreatitis, yes, surely, and those are the cases where need to be very skeptical. But
I think that should be a learning curve for everyone, who is watching. I'll come to you, Dr. Sumanta. That keep the suspicion always at the back of the mind. Let not the surgeon's judgment overrule what is in the pathology. Yes, Dr. Sumanta, you were saying something.
If you're doing a procedure for chronic pancreatitis and phrase procedure, and if you take up some tissues and send it for frozen section, they already lost the boat, because that pancreatic cancer is so nasty. So once you have a ragged margin and spill it in the peritoneum, so there's no point doing surgery, and you cannot convert it to on-table whipples. So frozen section, in the perspective of chronic pancreatitis treatment, I do not see any valid ground to do that. And next is so much of investigations we have got, MRCP and CECT.
Yeah, but if you tell me, being at KM now for 22 years, I have seen all the spectrum, and even the best of the endoscopists doing the best of the EUS and giving you an FNA, you can still miss it on a given day.
Yes.
It's just it is a message.
Yes.
So the idea is, completing the spectrum, that don't miss on certain findings. If you have a suspicion, send it across if you have a facility, let it come negative, and then you can have a comfortable good night's sleep rather than having the problems. So Dr. Manas, you have very nicely come up. What is your experience? It's out of this context, but what is your viewpoint on laparoscopic whipples? Having done such good PJ cases now, what do you think? How are you going towards that?
Jignesh, I have already started laparoscopic whipples. In my previous institution, I had attempted twice, but failed. I needed to convert it. Here in AIIMS, I started my first attempt. There also I failed. I converted, but my second attempt I became successful, and I've really gone through to laparoscopic whipples. It's a wonderful procedure. The only thing is that you need to have a very cool head and good patience. That's what is required. Nothing more than that. Otherwise, probably rest everything we are doing in other procedures. So it is just the anatomy.
It's a third block. It's anatomy and the third block.
It's a third block, and the anatomy is so clear. It is so comfortable. I mean, I feel from open it is much better in that way. But it is just the third block, as you rightly told. So laparoscopic whipples, somebody can just attempt. Probably is a graduated learning process. As we go from benign pancreatic surgery, we should also slowly get into laparoscopic whipples as well. And selecting cases is equally important. Ampullary tumors and the initial stages, unless and until you get that confidence of doing things very comfortably. But probably, again, selecting cases is the first and most important thing for any advanced procedure as you go and embark upon.
Yeah. Dr. Deb, another technical question for you. What have you done LPJ with a locking suture, like a V-lock or a, Stratafix, or what suture do you use?
I just use PDS, 20 PDS I use.
Okay.
Just to add on beginning laparoscopic whipple, I think if you're an alone surgeon, don't do it. You take another good surgeon with you who is equally competent. Otherwise, it's a long procedure. So end of the day, I mean, you'll be totally exhausted.
I think the way it is, we will have a session on this definitely. But what you rightly said is need to have two teams. And I have seen, I've visited even the Seoul Center as well as Professor Nagakawa, and we've got a fairly good series at KEM. Myself and Samir Rege have been doing it. So we approach from the right side, and definitely when we have a focus on a Gemas on some forum, two teams work up. One team is for the resection, and the second team does the anastomosis. And next time we vice versa. The anastomosis team will do the resection. We wash out completely, and because for one surgeon to focus and do the entire journey is a little bit of task. So I think we've already crossed more than 1 hour of fantastic discussion. Maybe I'd just like to have a take-home message from each one of you before I put the final points. So let's start with Dr. Dep Kumar Ray. Your take-home message for the audience today.
My take-home message is you need to select your case properly. Whatever you do, laparoscopic open, cystogastrostomy. I talk about cystogastrostomy, inostomy. And I'd say if the pancreatic duct is intact and a lot of big collections, they actually, if you just sit on them, they disappear, most of them. You don't have to operate on them. The only thing, if there is a necrotizing pancreatitis, as Manas said, more than 30-40%, especially the mid-body necrosis, those you need to do something on a later day. So, and do develop good suturing skills to be able to do it laparoscopy.
Okay, Dr. Manas, your take-home message.
I think my take-home message is very clear for the younger surgeons who are listening to this talk and discussion. No suture, no future. So the first thing is you need to learn intracorporeal suturing. I mean, there is no other way out. You can escape and upgrade yourself. I have told in my first slide, if you either you need to update or you get outdated. So please learn intracorporeal suturing. It's not a difficult job. Once you start suturing, even in the first thing that you should attempt is a GJ. That's probably one of the best thing to learn intracorporeal suturing after your endotrainer practice. Once you go and upgrade gradually from GJ to a subtotal cholecystectomy, then go and start doing this pseudopancreatic cells. Is absolutely not a difficult procedure. As they've told that you just need to select out cases. That is probably the first thing that is very much required as a surgeon need to upgrade himself. And once he upgrades systematic way, I think everything is possible. I mean, everything is possible in this world.
Okay, Dr. Kaushik, your take-home message for the audience?
Yeah, before I take over, I'd like to thank Dr. Dep Kumar Rai and Dr. Manas Kumar Sau. You may not, Dr. Jignesh, you may not be knowing him. When I was in first year, Dr. Manas Sau was my teacher. I mean, he was in third year in same college. And he taught me a lot of ABCs of surgery. So we are associated for a long time.
Yeah, pretty long.
Even I'm learning from him. I'm also a student.
Yeah. Dr.
I'm learning from all of you. Yeah.
Dr. Manas Sau, we have a long association, from 94 onwards, in fact.
Absolutely.
Anyway, the take-home message I would like to say, Dr. Jignesh, is in an advanced laparoscopic surgery, I mean, especially of pancreas, what you're saying, I want the young generation and everybody to be aware of complications also. Because we see a lot of patients getting operated in the higher centers and coming to us with the complications. And we in the periphery have to deal with the complications because they don't go back to the same surgeon. So my point of thing is that all the surgeons who are doing advanced laparoscopic surgery should be aware of all the complications and how to deal with them also.
That's a very nice. And Dr. Sumanta, your take-home message for the audience?
Thank you both, Dr. D.K. Roy, Dr. Manas Sau, for showing fantastic videos. And for junior surgeons who are watching, these 2 or 3 videos, they have clearly shown some basic stuff, that how to do suturing skill, how to align bowel along with your pancreas, how to retract, how to expose the field, how to clear the field. So these are the basics of laparoscopy, and this is a stepwise approach. As Dr. Sau said, they first learn all this lab basic stuff like cholecystectomy and appendectomy, then suturing the subtotal cholecystectomy, gastrojejunostomy, jejunostomy, then pancreatic. Pancreatic laparoscopy operation is far more advanced than your advanced laparoscopy skills. So it is clearly the way forward. Eventually, we will see all the benign pancreatic cases going to be done laparoscopically, and slowly we'll move towards the Whipples laparoscopically. The next thing we have not discussed in this forum at this point, that what is the future of robotic pancreatic surgery in India? And I think that is coming in a big way, because Whipples, as we have discussed, doing one surgeon's job, laparoscopic Whipples is a big thing, but that is possible robotic. So because robotic is less tiring and more precise, and I have seen lectures from guys from Mayo's Clinic, they feel more comfortable doing robotic and laparoscopic Whipples than open Whipples, because they think the anatomy structures are more clear, because you are seeing things 2.5 times bigger than what you'd see. So that's how the things are going to go forward, but that needs a lot of steps to go, and hopefully next 5-10 years down the line, we will talk in this forum in a completely different language. So thank you.
I think, so I think that was a great thing. What has come out, I would just sum up in terms of 3 T's. You need to be a good technician. You need to know the good technique, and then use the technology. This 3 combination will take you far ahead in doing laparoscopic surgery. And before I end this session, there's a beautiful saying, which I don't know how many of you know, by Theodore Billroth. He had made a statement that God put the pancreas in the back because he didn't want surgeons to mess around with it. So that was a very beautiful statement by the Australian surgeon, that he didn't want surgeons, and all of us today are all the time doing something in the pancreas. But it was a very nice, made in 1800. God put pancreas in the back because he didn't want surgeons to mess around. So with that, I think good night to all of you. And Dr. Deb, if you any of the concluding remarks, otherwise we can end the session here. It has been wonderful. A lot of learning from all of you today.
Thank you, Dr. Jignesh.
Thank you very much. Thank you.
Thank you,
Everybody.
Deb. Thank you, Sumanta. Thank you, Kaushik, and thank you, Jignesh. It was a wonderful time spent in the evening, and a lot of learning from me as well. So it was a lot good exchanges of ideas and sharing of knowledge. So hope to look forward to have more such interactions. Yes.
Same here.
Yeah, and I think we hope we should all meet in real time and not virtually. Let's pray to Lord Jagannath.
That is at least 6 months away.
Please, so I think Jagannath is going to take us to the COVID area.
It's only Lord Jagannath who can keep all of us safe.
Jignesh, Manas usually comes to me very often, but Jignesh, that was my plan from the Gemas to do a big meeting this year. Unfortunately, COVID took it away. But hopefully, if things are all right, then we'll do it next year. We'll do a 2-day program with all medical and surgical, which is very interesting.
I'm always happy. I'm always happy to come to Calcutta and have the Misty Doi. So I will not miss that opportunity.
It's very good. It's very good.
Okay.
Okay.
Take care, all of you. Good night. Good night.
Thank you.
Bye.
Thank you.
Bye.
Bye.